Hey guys, Julia Fowski here. I'm going to do your weekly education. This week we're going to discuss stroke. Every 40 seconds, someone in the US is having a stroke, and about 140,000 deaths can be attributed to strokes per year. So it's something that we transport often and we should know some stuff about. So that being said, this is my second take at this. I have condensed it way down. If any of you are interested in further discussing strokes, I would love to, and I have more information, but for the purpose of time management, we're just gonna scoot right on through. So we all know there's several types of strokes. You can have an ischemic stroke or a hemorrhagic stroke. An ischemic stroke makes up for about 80% of all strokes, and that's when a thrombosis or embolism gets caught in your circulatory system to your brain. The hemorrhagic stroke is about 20% and results from vascular rupture. A TIA, or a transient ischemic attack, is focal brain ischemia that causes sudden transient neurological deficits and is not accompanied by permanent brain infarction. Diagnosis is clinical, and a carotid endarterectomy or stenting, antiplatelet drugs, and anticoagulants decrease the risk of stroke after certain types of TIAs. A note on TIAs, oh, I didn't put it in here. So a quick note on those is a lot of times we'll take patients and we'll be like, oh no, they're just having a TIA. And so in reality, you don't know if it's a TIA or not. So all of these patients will be treated like they're having a stroke until proven otherwise. And the only way we know it's a TIA is when their symptoms resolve. So of course, if they're having symptoms right then you can't call it that. And if maybe they had symptoms and they've already resolved, then their chances of having a stroke increase greatly from that point forward. So that's like a little warning sign, and that doesn't mean that we don't need to take them seriously. That means that you are lucky, you got a warning sign, and it still needs to be taken very seriously. So your ischemic strokes, you've got several different kinds. Thrombotic is a blood clot. Embolic is plaque or clot formed elsewhere that's traveled to the brain. Cryptogenic, who knows? We don't really know what causes those. Lacunar, I think that's how you say it. I'm not real sure. Sorry if I'm mispronouncing that. Those are commonly in the thalamus, basal ganglia, or the pons. Large vessel occlusion involves significant portion of the brain, and they'll have major symptoms, versus a small vessel occlusion, which has limited portion of brain involvement, but maybe major symptoms that just might be limited to a particular part of the brain. So it's good to know your cranial nerves and which part of your brain controls what, so you can kind of identify maybe where the stroke is. Hemorrhagic stroke is made up of either intracerebral hemorrhage, subarachnoid hemorrhage, intraventricular hemorrhage, or a hemorrhagic transformation of ischemic stroke, which is 6% incidence. We all know the stroke signs and symptoms: facial drooping or paralysis, arm or leg weakness, speech difficulty, numbness in the face, arms, or legs, loss of balance, blurry vision. All this can be unilateral or bilateral. And to be able to kind of identify where your stroke might be located, or your patient's stroke, it's handy to know a little bit about the circulation of the brain. We all remember the circle of Willis breaks off into the anterior cerebral artery, the middle or medial cerebral artery, right? Well, middle cerebral artery, sorry, and posterior cerebral arteries. And those further break off into smaller capillary beds. And so the picture on the left is a little bit about circulation. Picture on the right covers about what area of the brain would be fed by particular arteries. So that's good information to have and know, as well as the lobes of the brain and kind of what they cover. So I will read straight off the PowerPoint for these next few slides. So if you're just listening, then you still get all the information. The frontal lobe controls your thinking, speech, movement, emotions, planning, and problem solving. Your parietal lobe, movement, perception of stimuli, orientation, recognition, spelling, and numbers. Your occipital lobe is your visual processing and color ID, and temporal lobe is your perception and recognition of auditory stimuli, memory, speech, emotion, and some vision. Your cerebellum controls your coordination, balance, and some speech, and your brain stem, pain sensitivity control, alertness, respiratory control, cardiovascular control, regulates body temperature, heart rate, swallowing, and breathing. Those are bad to have strokes there, obviously. Here's a quick reminder of your cranial nerves. I'll spare you the A&P review. If you don't remember those, I would encourage you to just go back and glance at them. So the anterior cerebral artery, it extends upward and forward from the internal carotid artery. It supplies the frontal lobes, the parts of the brain that control logical thought, personality, and voluntary movement, especially of the legs. A stroke in the anterior cerebral artery results in opposite leg weakness. If both anterior cerebral territories are affected, profound mental symptoms may result. This accounts for less than 5% of all strokes. Middle cerebral artery, this is the most common, and this is the largest branch of the internal carotid. So the artery supplies a portion of the frontal lobe and the outer and lateral surface of the temporal and parietal lobes, including the primary motor and sensory areas of the face, throat, hand, and arm, and in the dominant hemisphere, the areas for speech. This supplies blood to the basal ganglia, which controls voluntary movements, procedural learning, cognition, emotion, eye movements, contralateral weakness, etc. So this is covers a large amount of area, and this is why in some of the stroke scales they have such silly particular little things, and that is so we can get a better identification of where it might be located. So the posterior cerebral arteries stem in most individuals from the basilar artery. The posterior arteries supply the temporal and occipital lobes of the left cerebral hemisphere and the right hemisphere. When infarction occurs in the territory of the posterior cerebral artery, it is usually secondary to embolism from lower segments of the vertebral basilar system or heart. So you can see in the picture what a large area that might cover as well. So what do we use? We use preferably the Cincinnati Pre-Hospital Stroke Scale in our work. There's lots and lots and lots of other scales. If you have one that you prefer, then put it in there as well in your charting, but you will also need to go into the scale section or score section, I don't remember right now, and put in a Cincinnati Stroke Scale as well. So the Cincinnati is their face drooping? Is there an arm drift when they hold their arms directly out in front of them? And then their speech, is it normal or is it incorrect words or is it slurring? So abnormal, in all three of those being abnormal increases their, let's see if I put that in there. Dang it, no I didn't. All three of these being abnormal increases their stroke, or basically says they have more than an 83% chance of having a stroke if all three of these are abnormal. So it's notable for sure. In ZOL, you will document this under the vital sign tab. At the top, you'll choose scales on the, so you'll go into vital signs at the top, and then on the left, you'll choose the scales tab, and then you'll have to choose add new, and it will bring up an option 4 or 5 different scales, and you'll choose the Cincinnati Stroke Scale, and you'll complete those questions. It's not right now a closed call rule, thank goodness. You just have to remember to put it in. So that's cool. If you guys could do that, it'd be great. Your chart very well might come back to you if you don't have that in there. If any of these, if your Cincinnati score is normal or abnormal, please go ahead and put that in the narrative or history and physical as well. And make sure it also matches your assessment. And just so you're consistent with all your areas, make sure those 3 areas match. The NIHSS is the gold standard for acute hospital scales, and clinical assessment tool. This provides a quantitative measure of stroke-related neurological deficit. It evaluates acuity of stroke patients, determines appropriate treatments, and predicts patient outcomes. Very pretty well, actually. This is also valid for predicting lesion size and can serve as a measure of stroke severity. Also, it's been shown to be a predictor of both short and long-term outcome of stroke patients. So this is something you will want to be familiar with. You don't necessarily have to perform this on your patients, but it's good if you can ask the sending facility, hey, did you guys do an NIHSS or NIHS? And if they did, put that number in your chart and make sure you report that number to the receiving facility as well. And then as well as when you're dropping off the patient, if you can help them perform this immediately or quickly-ish, then we can go ahead and document that score in our chart as well. That just helps me with patient follow-up and studies and stuff like that. So the NIHSS consists of 15 items, 15-item neuro exam with emphasis on level of consciousness, language, neglect, visual field loss, extraocular movements, motor strength, ataxia, dysarthria, and sensory loss. Sorry, I'm missing a comma in there. Ratings for each item are scored on a 3 to 5 point scale, with 0 as normal. Then there is an allowance for untestable items. Scores range from 0 to 42, and the higher the score, the worse their prognosis will be. So they say this takes less than 10 minutes. If you're familiar with it, it could possibly take less than 10 minutes. It might take a little more than 10 minutes. So just be familiar with what this scale kind of does. If you need information on this, I can absolutely send you information regarding this. I also have some laminated copies somewhere with the actual pictures that they ask, that they incorporate, and some other forms that you would need in order to perform the scale. I will gladly send it to you if you're curious about it. It is something we need to be somewhat familiar with. So if you're not, then either reach out to me or do some research and kind of familiarize yourself with what they're asking, what they're testing, and how we can give them information to help speed up the patient's care at the receiving facility, because that is the goal. Time is what you're fighting against here. So over 25 on the NIHSS, your score, your patient would be considered very severe. Severe would be 15 to 24. Mild to moderately severe would be 5 to 14, and a mild stroke would result in an NIHSS of 1 to 5. Scores of less than 5 have an 80% discharge rate on survivors. Scores between 6 and 13 typically require acute inpatient rehab, and scores over 14 frequently require long-term skilled care. So what do you want to know? How will this affect you? So some things you're going to want to know for your stroke patient are going to be the last known well time for sure. You're going to need to document this somewhere, and remember to tell the receiving facility this information, because that's go time. That's where the clock starts. That's a very, very important time on all stroke patients. Even if you're 24 hours out, it's good. You need to know the last known well time. Also remember, if they didn't see the patient, so say the patient lives alone, 92-year-old male lives alone, he talked to his family last night before he went to bed, and then he went to bed, and then his caregiver came by in the morning to wake him up, and he then was showing stroke symptoms, his last known well time would be the previous night when he was speaking to his family. So because we couldn't identify at any point between that time where he was normal. So the last known well time would be the last time he was known to be well. So keep that in mind. If that puts them out of the window, that puts them out of the window. It's still important. There's still some things they can do. So you're still fighting against time as well. So that doesn't mean slow down, take your time. It means just treat this like a regular 2-hour stroke, and you're doing what's right. So also, all altered mental status patients and stroke patients need a recent blood sugar documented. And they're going to want to know some stuff like, how did they present? When did they present? Is it bilateral or unilateral? Excuse me. Are they stumbling? Are they slurring? They're going to want a thorough baseline assessment. So what do you assess when you get there? And then what do you assess when you drop off the patient? Is that the same? Is that different? did they deteriorate during the 20 minutes you had them, or 2 hours you had them, or however long you had them? So do your own baseline. Don't leave it up to them to tell you. Just do a quick assessment and then do another one when you drop them off, and then ask yourself, are these the same or are they different? And then report that. So some other things you're going to want to know is this a hemorrhagic or ischemic stroke? Have they had a CT? Is it negative for a bleed? Do they have any recent trauma that might put them out of the range of people who can have lytics? Do they have a history of blood clots? Are they on blood thinners? Are they a good candidate for thrombolytics? Don't delay your transport for any of these things. Just try to do these things while you're packaging and going, or ask these questions, or read the chart on the way to the hospital if you can. So save the penumbra. This is the area around the stroke that, or the area that the stroke is affected, and this can be saved by the amount of collateral blood flow around the area. So, but time is not your friend. Time is tissue, and this is someone's life. Tissue is someone's life. So how do we help in our 15 minutes or 2 hours of having this patient? What can I do? For a hemorrhagic stroke, there is, well, in both types, you're going to control their hypertension. Hemorrhagic stroke surgery is going to be your definitive treatment. And so you're going to want to, you're going to want to rapidly take them to the receiving facility and manage their blood pressures as well as you can. So for an ischemic stroke, they can use clot busters or TPA, tissue plasminogen activator, and you're going to want to control the hypertension, obviously, as well. And then sometimes the definitive treatment is a clot removing device or a thrombectomy, and that's really cool, by the way. The treatment to control hypertension is our SMG 406, hypertensive crisis with neuro changes. This also covers hypertensive crisis with chest pain. That requires a different treatment. For the purposes of this stroke education, we're only going to cover the hypertensive crisis with neuro changes. So if you're not familiar with the chest pain, then look, but for right now, this is what we'll discuss. So in order to be treated under our protocol for hypertensive crisis, they've got to have a systolic over or equal to 210, and I couldn't do the over or equal to sign, so I just did the over sign. Sorry about that. So systolic over or equal to 210, or a diastolic over or equal to 120. If they have either one of these with neuro changes, then you can start a nicardipine drip at 5 milligrams per hour, and you can titrate that 2.5 milligrams per hour, titrate that up every 10 minutes or so with a max of 15 milligrams per hour. And you're going to want to monitor their blood pressure every 5 minutes. If that's still not doing it, you can also give them labetalol, 20 milligrams, and you can repeat 10 milligrams every 20 minutes with a max of 300. This is contraindicated with patients with asthma, CHF, cardiogenic shock, severe bradycardia, or first-degree block. And last but not least, you can give Lasix 0.5 milligram per kilo IV. Before you give Lasix, I would make sure their kidneys functioning and make sure that they don't have any other contraindications for that, but most people are good. If their kidneys aren't functioning well, you can still give it. It just takes a little bit longer to get out of their system. And the renal doctors don't particularly care for that in their patients. So hypertensive crisis pearls. Goal is to slow the blood pressure down moderately by no more than 25% with the goal of resolving the chest pain or neuro symptoms. Our goal will also be to keep it under the documented limits for their lytics or thrombectomy. Rapid reduction of that blood pressure may worsen their status. So if it's super high, just bring it down slow. And if you don't get it all the way down where you need it, that's okay. Make some progress, and that's all you can do. So don't drop it. Don't bring it down too fast. If chest pain or pulmonary edema present, also follow the appropriate SMG for that. Elevate the head of your stretcher 15 to 30 degrees. Do not flex their neck. You do not want to increase their intracranial pressure if you can at all avoid that. So raise that head. Assess their blood pressure in both arms if you can, and continue cardiac monitoring and obtain an EKG, of course. Get you blood glucose and do your scales, your baseline, and your follow-ups, and confirm previously placed IVs and ET tubes. And usually a patient with hypertensive crisis obviously will have a history of hypertension. So, big surprise. For ischemic stroke, the treatment is right off the bat would be thrombolytic therapy. Alteplase or Activase is a tissue plasminogen activator, and this can be given within 3 hours after the onset of symptoms. They're actually saying up to 4.5 hours now. The dose for this would be 0.9 milligrams per kilo, not to exceed 90 milligrams total dose. And 10% of that total dose will be administered as an initial IV bolus over 1 minute, and then the remainder will be given over 60 minutes. So they must have neuro checks and vital signs every 5 or 10 minutes, then Q 15 minutes for like the first hour, then 30 minutes after a while during the post TPA administration. I would encourage you guys just to take their blood pressure every 5 to 10 minutes. And then you don't have to worry about whether it's time for that 30 minutes because you're already doing it. So there was something else. Oh yeah, so the Alteplase is not something that's in our protocol. It would be something that you would start and give at the sending, or you might pick up the patient while they're getting it or shortly after they've gotten it. And so you're going to want to be familiar with that medication and what some potential adverse reactions or side effects might be, how to and when to stop it if you notice something. Some contraindications that would prevent them from getting it in the first place would include recent surgery, recent GI bleed, or hypertension that's over the limits, acute pancreatitis, significant liver dysfunction, pregnancy, don't give it in pregnancy, hemorrhage of any type, blood thinners, and others as noted on the manufacturer's packaging. So if your patient did recently have surgery and you're still in that 3-hour window, you're still fighting against time. Just because they don't meet the requirements to be able to have Activase does not mean that you do not need to hurry. This still means that you still need to move with a purpose and get your patient to the receiving facility as quickly as possible, because time is still tissue and there's other ways that they could go in and deal with that. So for the Activase, you're going to control their hypertension immediately. If they haven't gotten it yet and you're trying to get them to the receiving facility so they can get the Activase, they must have a systolic. Once they get there, before they can start the Activase, they'll have to have a systolic of less than 180, maybe less than or equal to 180. Sorry about that. And a diastolic of less than or equal to 105. So to treat hypertensive crisis, it's either over 210 systolic or over 110 diastolic, I believe. Sorry guys, if my memory fails me. For this, it must be under 180 over 105. Both of those have to be in the green, I guess, to meet criteria. You can, if your patient's maybe just a little bit over 180, but not quite to the 210 mark, we can utilize our resources to go ahead and get medication started at the sending facility. You can call your medical control to get an order. You can get a receiving or sending physician's verbal order and go ahead and start something that can help get that blood pressure down. Don't wait till it gets over 210 to start treating it. You can work with the rest of the healthcare team and go ahead and get that ball rolling and get something going. You're going to want to limit their IV fluid and keep from raising the blood pressure. You don't want to put more volume in the tank. That's going to increase the pressure. And so you don't want to do that if you can at all avoid it. So the 2018 guidelines for early management of acute ischemic stroke, this is for pre-hospital, and this is kind of what they've put out from American Stroke Association, has kind of put this out for all pre-hospital providers and the general education for the public. So the first thing is activate 911 system, use your pre-hospital notification by EMS. This should be completed for all patients with stroke symptoms. We do that when we utilize our Pulsara or when we are calling report. That is pre-hospital notification. And if you have the option to call report 20 minutes out and say, hey, I've got a potential stroke coming in, and then call your report 5 minutes out, if they had to call a stroke team in, or if you're familiar enough with the facility and you know, well, they've already got one there, or no, maybe they don't have a stroke team there and they have to call a neuro in, then give them a little bit more of a heads up. So you might try to familiarize yourself with the hospitals that you're taking the patients to and see what they would prefer. These guys also say EMS should have a standard triage protocol which supports a stroke screening tool such as the FAST, Cincinnati or Los Angeles. We prefer the Cincinnati in this area. Other areas may prefer something else. As long as you have a standardized triage protocol that supports the stroke screening, then go with what's recommended in your region. Patients with a positive stroke scale should go to the closest facility that can capably administer IV alteplase. Keep in mind your blood glucose, your blood pressure, last known well time, and your stroke screening tool are all going to be, those things are going to, they're going to want to know at the receiving facility, so have them ready. So your guidelines for the hospital part are they must have organized protocols for stroke patients as well as a designated stroke team to meet certain criteria to be a primary stroke care center or comprehensive center, depending on what they are, I guess. Blood glucose should be assessed prior to IV alteplase. Blood pressure should be slowly lowered to less than 185 systolic and less than 110 diastolic prior to IV alteplase. And it's got to be maintained under 180/105 for at least 24 hours after. So if they've already given it at the sending, it's a drip and ship sort of thing. Maintain that blood pressure less than 180/105. And you'll work off of sending facility orders should you need to medicate for that in flight. Their goal is to get a CT of the brain within 20 minutes of arrival. Door to needle time of less than or equal to 60 minutes is their goal. And they have to meet that goal a certain amount of times each month or they lose their certification to be a primary stroke center or a comprehensive stroke center. And that's huge. So any way we can help our receiving facilities meet that door to needle time of 60 minutes or less is great. Every minute counts. Even 1 minute, you're either 60 minutes or you're 61 minutes. And 61 is over. So keep that in mind. Every minute really does count. They also are encouraged to use the NIHSS for their screening, and all of their patients have to have a dysphagia screening. The 2019 update says basically there's a few more things, but these were the important ones that affected us. IV aspirin should not be given within 90 minutes after the start of IV alteplase. The standard dose can be beneficial in patients who wake up with AIS symptoms or in patients who have an unclear time of onset of over 4.5 hours. It used to be 3, now they're kind of saying 4.5-ish of stroke symptoms from the last known well time, and who have a DWI lesion smaller than 1/3 of the middle cerebral artery territory and no visible signal change on fluid attenuated inversion recovery. So imaging, sorry. So basically that says that they're kind of extending the amount of time allowed, and so you still want to hurry, and they still might be able to get lytics even if they're past their time. Also, tenecteplase may be administered instead of IV alteplase in patients ineligible or who have contraindications to receive alteplase. Keep in mind that this is usually given for heart stuff and not head stuff, and the doses are different. And there have been some cases in the past that Med errors have occurred because people mistakenly think that these are the same thing, and they are not the same thing. So know that and familiarize yourself with the difference in the two. So IV alteplase, our goal is to initiate the drug within 3 to 4.5-ish hours of symptom onset. We discussed our dosing already, 0.9 milligram per kilo with a max of 90 to be infused over 60 minutes. First 10% goes in over 1 minute. And then we'll continue to monitor their vital signs frequently, the neuro checks, and the hospitals will do the NIHSS. And we'll help them as needed. So post-alteplase therapy, monitor for neurodeterioration. They have to do the NIHSS and vital signs Q 15 minutes during the infusion and for the first hour after. After 30 minutes, then every 30 minutes for the next 6 hours, then hourly after the 8th hour until 24 hours and yada, yada. So long story short for us, just do 10-minute vital signs. That's pretty good. Unless they're out of a normal range, then you can increase that as often as you want. Make sure we are monitoring for major and or minor bleeding, because minor could likely turn into major at some point. This is the most common adverse effect. And we'll control their blood pressure. We'll try to maintain it under 180 over 105 for at least 24 hours. So if they had alteplase last night at 9 p.m. and here it is the next day at 9 a.m., we're still trying to maintain that blood pressure less than 180 over 105. Also monitor for hypersensitivity. Angioedema has been noted during and up to 2 hours post-infusion. So thrombectomy would be the ultimate definitive care and would be definitely the definitive care treatment option for patients who can't get lytics. So mechanical thrombectomy with a stent retrieval can be considered for AIS patients with large vessel occlusion within 6 hours of symptom onset. Again, we'll maintain that blood pressure of 180, less than 180 over 105 during the procedure and at least 24 hours post-procedure. So if they had a thrombectomy yesterday and we have them, we're still maintaining that blood pressure lower, and we want to know what time the thrombectomy was if we can know that, so we can report that. So this is basically a thrombectomy. They send like an introducer in, and then they introduce this little net thing, and then they expand it, and then the clot gets kind of caught up in it and grips on it, and then they suck it back out. So it's pretty cool. So the Joint Commission stroke certifications are listed here. Your hospitals, your smaller hospitals or medium size might be an acute stroke ready hospital. That means they can give lytics and transfer, and we see a lot of that. And they have neuro available either in person or via telemedicine. So a primary stroke center, they have IV thrombolytics and medical management of a stroke. Again, neuro is in person or via telemedicine. A thrombectomy capable stroke center can give lytics. They can also do a mechanical thrombectomy. And neuro would be available in person or telemedicine. Written call schedule for attending MD, not necessarily a, well, yeah, we'll stop there with that one. So a comprehensive stroke center offers IV thrombolytics, endovascular therapy, clipping of an aneurysm, coiling, stenting of carotids, carotid endarterectomy, and this meets all of the stroke patients, meets needs of all stroke patients, and has a written call schedule for the attending MD. So that's 24-hour coverage and the highest services. So the DNV stroke certifications are very similar, basically the same thing. And then keep in mind that some hospitals can provide like thrombectomies, but it's not on a 24-hour basis. So that does not mean they can be a primary stroke center, because they have to have these things offered or an on-call schedule for 24 hours. So either way, long story short, you need to just be familiar with your area, what hospitals can do what, and where you might take your patients. And if it's a scene versus an interfacility, if it's someone bringing the patient to you on the pad, say, hey, does this local hospital here have lytics? Does this patient qualify for lytics? Do they need to be seen here first, or are we just going to take them? Is it quicker if we just hop in the aircraft and go? Most likely, that's a judgment call and on an individual patient basis. So do what's best for your patient. So early notification, this is huge, and this is something that a lot of hospitals report back to me. They give me feedback on this. BSA Northwest and Amarillo both use the Pulsara app, and we have it on our iPads here in Texas and Oklahoma area, and you can also put it on your personal phone. It has an individual login for each crew member, or if you log in on the iPad, then it's just like Apollo 4 is the name of the crew member listed. And so BSA is very good about giving me feedback. I work closely with their doctors and their stroke team, and there's a whole task force there, and it's a big group of people. And so I go to monthly meetings, and they give me really good feedback on, did we make it? Did this patient do well? And did we make the right choice? Did they make the right choice? Can we educate the sending facility so they can provide better care for their patients? That's something we do very often. And I would encourage you guys to make sure that your sending facilities are also kind of on the up and up on what the receiving facilities protocols are, so that everybody's on the same page and working towards the same goal. So familiarize yourself. If you're in the West Texas area or Oklahoma area, familiarize yourself with how to log in on your iPad or your cell phone. I remember there for a while, I didn't remember my password, and we couldn't get on our iPad. So that was kind of there were several times that I didn't get to use it, and my feedback wasn't as good. It's really hard to track down, to follow up on those patients. And it's really hard to ensure that you gave the proper care, because we know that pre-hospital notification saves lives. We know by evidence-based studies that there's a reason why it's out there, and it helps people and it speeds up the process. And you can look at the numbers, they speak for themselves. It actually makes a big difference if you give the hospital a little advance notice that you're coming with this patient. They can be ready for you and shave 5, 10, 15, 20, 30, 45 minutes off even. So know how to log in and use that. Also, if you're using Pulsara, you can send a picture of the EKG, and it's also for STEMIs too, by the way. So send a picture of their driver's license or insurance information so they can start the registration process before you even get there. They can have the CT ordered. And this does meet HIPAA criteria, or it is HIPAA compliant, excuse me. It does not save on your personal device when you take pictures through the Pulsara app of their identification. It doesn't save it on your phone. So it sends it, and then it's off, it's gone. So it is HIPAA compliant. And it's also really neat that you can look up a follow-up on your own device, the next day. You can say, hey, I wonder if that's still an active case, and what did they do? And on your STEMI patients, it's really cool. I've actually gotten pictures of the before and after of the actual stenting process. And, within 24 hours, we dropped off the patient. She was having a big fat MI. And within 24 hours, we had picture evidence of how that use of Pulsara saved her life. And we moved with a purpose and with cat-like reflexes. And so we did good on that. We can do the same for strokes with the same Pulsara app. And so it's really a cool thing. So also be aware that at the receiving facility, and this is for all facilities, they may want you to go directly to CT before you take the patient to the room. This is good and fine, and probably good for your patient as well. So if you're not going to a facility that utilizes the Pulsara app, then be sure to call a radio report whenever it's possible. If you're not able to call a report, if you're busy, then have your pilot, have dispatch call and let them know, I have a potential stroke coming. I don't have anything further. They're busy, or here's their vital signs, or whatever else you need to tell them. But as long as they hear the word stroke alert or potential stroke, they can let the receiving facility know. And if nothing else, they can have a team ready and a room available. Most facilities will want that CT and EKG within 10 minutes. They'll want labs within 15 to 20, and they'll want an MD at the bedside as soon as possible. So they may meet you literally at the door. The sooner they know you're coming, the better they can coordinate their team prior to arrival, and the quicker they can get that patient where they need to be. So for documentation, make sure you have an assessment that matches your stroke scale, that matches your both assessment and narrative section. So all three of those areas need to match: your stroke scale, your assessment and your narrative, and then your assessment section. They need to match. If your patient changes conditions or they deteriorate or their neuro status changes, then I need another assessment with further follow-up in the narrative explaining what happened. And so a blood glucose also must be documented on all patients presenting with stroke-like symptoms. And if you can include stroke or CVA in your impressions, then even if they're out of their window, even if it's what you might think is a small TIA, if you can, because as far as TIAs are concerned, it's a stroke until proven otherwise, and then we can pull the data later and really decide as a group, did we do good? Can we do better? And can I learn anything from this? So what else do I need to know? I'm sure there's lots of other things that that we need to know. If there is anybody who's interested in knowing more about the NIHSS scale, like I said, I'll be more than happy to send you some stuff on that, or basically anything regarding stroke, location, any of that, especially the charting. If I can help you guys in any way, please don't hesitate to let me know. I think we're all done here for the quick nitty-gritty. Yeah, so okay, thank you guys for your time. I hope you all have a wonderful day. Fly safe. We'll talk to you soon.